very much for having me, Dr. Minocha. So I'm Chris Marano. I'm a geriatric psychiatrist at University of Maryland, Baltimore, and we've been asked to speak today about some of the pharmacological management of the behavioral disturbances of dementia that our patients may exhibit. Like I said, this has been a passion of mine for a number of years, is working with folks with dementia, particularly with behavioral disturbances. And I'm glad to have the opportunity to speak with you all. All right, so first off, I don't have any disclosures, and I should mention there are no FDA-approved treatments for the behavioral disturbances of dementia. So I will talk about kind of the unlabeled and unapproved use of multiple agents, antipsychotics, antidepressants, and anticonvulsants. So what I'd like to do today is first just talk about like why these are important. What are the significance of the neuropsychiatric symptoms of dementia? Kind of provide a practical approach to their evaluation and management, and then go through the evidence for the different medications to treat the neuropsychiatric symptoms of dementia. So, this is nothing new to anyone. We always think about the cognitive and the functional symptoms of dementia, and they're really disease hallmarks. But neuropsychiatric symptoms are universal, and these are a lot of the symptoms that really end up with a lot of adverse consequences for patients and for their caregivers. Worse quality of life, more disability, accelerated cognitive or functional decline, greater caregiver burden, which can result in earlier institutionalization and accelerated mortality. I always think of the goal of care in dementia is really being quality of life, and that quality of life is both the patient as well as their loved one or their caregiver, and really these neuropsychiatric symptoms kind of adversely affect quality of life for both patients and families. So what are the symptoms we think about? Well, I put this up. This is something called the Neuropsychiatric Inventory. It was developed by a neurologist, Jeffrey Cummins, about 25 years ago, and it was mostly used in research as kind of to quantify neuropsychiatric symptoms, but I also use it a lot clinically. I find it's really a nice list to kind of make sure we're covering all of our bases when talking with patients and families. So what were the symptoms that we see? Well, there's certainly the psychotic symptoms, delusions and hallucinations, kind of agitation or aggression. This is very much a catch-all, and I'm sure as Dr. Morrison probably talked about earlier today, we really need to drill down on what we mean by agitation, better in order to adequately treat it. Depression is very common, as is anxiety. Don't see much elation or euphoria. Have apathy or indifference, which can be really difficult to distinguish from depression. People may become disinhibited, irritable, a lot of motor disturbances, pacing, rummaging, reversal of sleep-wake cycles, and problems with appetite and eating, not just forgetting to eat, but different food cravings. I put this slide up just to kind of show how prevalent these symptoms are. So this is a study that some of my former colleagues at Johns Hopkins had done, where they went to a county in Utah, Cache County, many years ago, and kind of used Medicare rolls to enroll everyone over 65, or invite everyone over 65 to participate in this study. The idea being to sort of find out how many folks had cognitive impairment and dementia, and then follow those folks over time. So the important point here is, like, just look at this. What you have at the bottom is each item from the neuropsychiatric inventory. And each box is sort of like the prevalence, over 5 years. And really what you can see is how common these symptoms are. Over 5 years, 60% may have delusions, 40% hallucinations, 50% agitation, 80% depression, 70% apathy. Elation or euphoria, we don't see much of that. Really, the take-home message is if you look over 5 years, people have any symptom, almost 100% of patients will exhibit some neuropsychiatric symptom of dementia. So we know this is out there a lot. So now I just want to talk about kind of a practical approach to how we can approach to these symptoms, and with an emphasis on some of the pharmacological treatments that we have. And just to give credit to some of the folks that I've worked with who've helped develop this model, and I'll use a case vignette, very basic case vignette, just to kind of go through some of the decision points that we have. So this is one patient that treated. We have someone you might see in primary care or in a specialty practice. So you get a phone call from the husband of your 82-year-old patient with moderate dementia. And over the past 5 days, she's become increasingly confused, agitated in the evening, including trying to leave the house, and isn't sleeping at night. So what do you want to do? I put this up, the first two options are pharmacologic medications. And really the point here is we really need to evaluate someone with dementia before prescribing any medications. This is really probably the most important slide I think I put up. Is it really thorough evaluation is essential. Can assume nothing and ask lots and lots of questions. People say, my husband's agitated. What does that mean? Agitation, does that mean when trying to give ADL care? Is that sundowning and trying to get out of the house? We really need to describe the behavior. The other thing we really want to know is, are there any other new physical symptoms which could give us a clue as to what's going on? Did someone fall? Also, have there been changes in caregiving? I don't know if you're talking about an institutional environment, is there a family stressor that's going on? The other thing is really to know what is someone taking in. I always tell, I don't know what kind of electronic medical record you have, but we use Epic, and it's really not the greatest for medication reconciliation. So I always say, bring in the bag. Let's see exactly what someone is taking in. And really important, and I put this work for my psychiatry colleagues, is to do a thorough physical examination. I can tell you over the years, we've had people admitted to our unit who've had agitation from an undiagnosed hip fracture, or agitation from an undiagnosed retroperitoneal hematoma, and from multiple other issues. So really important that we do a thorough physical examination and labs and other kind of investigations as indicated. And what we're trying to do here is rule out delirium. So is there an adverse drug reaction? Is there polypharmacy or drug-drug interactions? Could this person be on an anticholinergic or a benzodiazepine or an opioid? Is there an infection? Think also about urinary tract infections, respiratory infections. They've been on an antibiotic and had a stiff infection. Are they dehydrated or hypoxic? Pain, huge thing. Particularly if you can't express that you're in pain, if you're aphasic, this can be a real, a very significant cause of agitation. And same thing along with things like elimination, if someone constipated or they retaining urine. If we've done that, the other part of it is, and I know Dr. Morrison talked some about this, is really trying to look like what other identifiable etiologies may be out there. Is there an environmental precipitant? Often, early in the course of dementia, people may be understimulated, and later in the course, it may be easy to be overstimulated. Is there a lack of structure? Is someone sleeping, all day and then up all night? And how's the caregiver approach? Particularly someone who has difficulty understanding. Is the caregiver explaining what they're doing? Are they rushing? Could there be an underlying mood disorder or psychotic disorder that someone is reacting to delusions or hallucinations, or irritable from a mood disorder? Could this be to their cognitive symptoms? If you're aphasic and can't express what's going on, that's an intense source of frustration, and oftentimes can resolve it in in aggressive behavior, or if you kind of not recognizing the world around you and someone comes up and suddenly wants to, change your clothes or change your diaper, give you a pat, your first reaction may be fight or flight. And, you'd want to hit them. Also, you think about something like sensory deprivation. If you're not getting any input, like from vision or hearing, that's really going to be can be a source of distress. So, kind of to take that idea, into a practical case. So you bring in your patient and her family and you find that she's wandering the home until 4 a.m. She's wakens at 2 o'clock in the morning. She lays on the sofa and watches TV most of the time while awake. You really don't see anything going on. No pain, no falls, no changes to her bowel or bladder habits. She had unremarkable labs and physical examination or mini mentals about where it's been. So what do you do here? And really, I think that the issue here, and I put this up as to say that medications are not our really first line of defense here. Behavioral management is. So wouldn't start someone on Zolpidem or probably any sleep aid, I think, and nor can you reason with people who are sundowning. I think the things you want to think about is educating about the importance of sleep hygiene and regular activity. Consider interventions like a door alarm to prevent someone from wandering out, and think about structure like an adult medical day program. So family enrolls Mrs. K in an adult medical day program, tries sleep hygiene and installs door alarms, and she's doing well, but then you get this urgent phone call. She's again up all night for the last couple days, combative with family when assisting with their ADL care, and she can't say what's troubling her. So now we kind of know that we want to ask everything, what's going on and what's going into the body, and we learn that her husband's giving her Robitussin maximum strength nighttime cough DM, and this is an actual situation that I have with a patient. And I looked up, well, what's all in there? Well, we see it's a combination of dextromethorphan and doxalamine for cold symptoms. Well, doxalamine is a very, very potent anticholinergic medication. And it turns out that she now has a palpable bladder with suprapubic tenderness. You look at her bladder scan, there's 1,000 cc's of urine, mini mentals down to 7, and you can see what we have is urinary retention from a highly anticholinergic over-the-counter med, causing kind of delirium and agitation. So in this case, you may straight catheterize them, stop the offending medicine, provide some family education about over-the-counter meds and their anticholinergic properties. And in this case, your symptoms resolve, but about 8 weeks later, you get another call. And here it's a call from a nurse at the day program. And these, at least in my experience, that's when you only get calls from a day program if there's concern of violence towards somebody else. And over the last several days, Mrs. K's last several weeks, she's been progressively more irritable, had a verbal altercation with a peer over a baby doll and threw the baby doll. Actually, we had that situation a few minutes ago with the baby doll when I came off our unit. So here, again, we see her, our delirium workup is negative, there's no apparent environmental precipitant. Really, the day program staff is concerned for the safety of other patients. So after reviewing her meds and checking the EKG, the question is, well, what do we do next? So here, we can think about some medication alternatives, and hopefully by the end, we'll figure out what may be a most appropriate alternative. Or we can maybe keep Mrs. K out of the day program for 2 weeks and reevaluate. So the point here is you become to a decision tree when you have to decide whether to treat with medicines. And this really means, does the disturbance rise to kind of a level of severity that needs continued treatment? Are we affecting patient quality of life or functioning, caregiver ability to care for the patient, which also affects quality of life and functioning? Is this disruptive to a care environment or dangerous to other people? The other kind of thing we think about, have non-pharmacologic approaches failed, or really no other medication options, or there's some urgency to manage the situation. And always, I know when starting with medications, I really want to educate family and caregivers that there are some behaviors that are really unlikely to respond to a medication, things like wandering and rummaging, sort of setting expectations. So before we kind of talk about, well, what specific medicines might you think about in different situations, I just want to run a little bit through what is the evidence for the behavioral disturbances of dementia for pharmacologic treatment. This is not an exhaustive kind of overview, but I just want to highlight sort of some of the bigger trials. So we do know, we think about antipsychotics for agitation or psychosis in dementia. And if you look at the data, yet they do show some effectiveness, but it comes at the cost of significant side effects. So if you look like a low dose of haloperidol, a study done many years ago for delusions and hallucinations, might reduce these symptoms by about 60%. Trials show about similar efficacy with the atypical antipsychotics. Interestingly, there is the most evidence with risperidone or aripiprazole, though the studies, really have been no studies for the last 15 years because of the black box warning, which we'll talk about next. The other thing we do know is that there is some risk of recurrence after discontinuing an antipsychotic. This was a study done a number of years ago that was in the New England Journal of Medicine. And basically they treated 180 dementia patients open label with risperidone for psychosis or agitation at a mean dose of about a milligram a day. And of those 180, 112 met their criteria for response, and 110 were randomized to continuing the risperidone for 32 weeks, continuing for 16 weeks, then placebo, or just placebo for 32 weeks. And really what they found was, in the first 16 weeks, more than half of the people in placebo relapsed, and a third of the people in risperidone relapsed. And in the second half of the people who'd gone from risperidone to placebo relapsed, and 15% relapsed in risperidone. So yes, there is a risk of recurrence that we need to be aware of. But the thing, as we mentioned, and we'll talk a little about more, is this concern about side effects. And some of this effectiveness comes at the cost of side effects. And a lot of that depends on what receptor may be affected. So we think about the dopamine 2 receptor, and that's what causes some of the Parkinsonism that we may see with these meds. With blockade of the muscarinic anticholinergic, the M1 anticholinergic receptor, you may see cognitive deficits, dry mouth, the constipation, urinary retention. The histaminergic blockade you see in some of the new generation or second generation antipsychotics can cause sedation, which sometimes are used to therapeutic benefit, weight gain, and dizziness. Alpha blockade can cause hypotension. Orthostatic hypotension is a big problem with these meds, which can result in falls and then subsequently hip fractures. And really the big one is that there is this FDA black box warning. So in 2005, the FDA issued their highest level of warning, the black box warning for the atypical antipsychotics in dementia. And basically saying that, very simply, they looked at the studies of the atypical or second generation antipsychotic drugs, and they found that, when you pooled the trials, that people who are treated with these medicines are at increased risk of death compared to placebo. So over like 10 weeks, the risk of death between a drug-treated patient and a placebo-treated patient was 1.6 to 1.7 times. So you figure this is, a population where you may expect a high level of mortality. About 2.5% of the people in the placebo group may die during the trial, more like 4 to 5%, 4.5% in the drug-treated group. And The causes of death were varied, but most really were sudden death, sudden cardiovascular death, or heart failure, or infection, pneumonia. Now, when this first came out in 2005, it was just for the second generation or atypical antipsychotics. The FDA actually extended this warning in 2008. So sort of the initial move was, well, we'll go back to some of these older medications like haloperidol, but we soon learned that these meds actually probably have a higher risk of death even than the second generation medications. So we know, okay, so there's some evidence that antipsychotics may work, but it comes at a cost. What about some of the other classes of medications we will often use to treat neuropsychiatric symptoms? So I put this up, the idea of, well, what about the idea of using SSRI, selective serotonin reuptake inhibitors, as a primary treatment for agitation in folks with Alzheimer's? So this was a trial I was involved with about 10 years ago, the CITAD trial, where we basically used citalopram at a target dose of 30 milligrams versus placebo to see if it helped agitation in Alzheimer's. And the interesting thing about this study is that we did find it reduced agitation and caregiver distress, but there were concerns about cognitive adverse effects. The treatment group had a lower mini mental state exam score at the end of the one, and there was this question about potential cardiac adverse effects. So we used to think of citalopram probably as the safest of all SSRIs and didn't worry about anything cardiac side effects, and it was dosed from about 20 to 60 milligrams, and the target dose for the study was 30. Well, it turns out about halfway through the study, the FDA issued a drug safety warning of kind of dose-dependent QT prolongation with citalopram. So we went back and had to check EKGs on everyone, and they said you really shouldn't go above 20 milligrams in people over 60 years old. So kind of we don't know. Yes, we found in the study that QT was prolonged. What's the clinical significance? Not sure, but it kind of left kind of a gray area in the literature. The other thing we know is that the other thing we think about using antidepressants a lot, we know that depression is very common in dementia. What about antidepressants for dementia? And there you really don't have good evidence. There's actually more trials out there that show no benefit versus placebo than trials that show a benefit. And even the last two trials were large multi-center trials, and both of them looked at sertraline. One of them also looked at mirtazapine, and in neither situation did the active treatment do any better than placebo. We talked about, yes, antidepressants are safer than antipsychotics, but there still are safety concerns. So I mentioned the FDA drug safety communication for citalopram, kind of recommending a maximum of, noting dose-dependent QT prolongation, kind of maxing the dose at 20 milligrams for hepatic impairment if you're over 60, or if you're taking a cytochrome P450 2C19 inhibitor. And these are very common. All proton pump inhibitors are 2C19 inhibitors. So our dose is limited. Now, the sister drug, escitalopram, which is a racemic isomer, did not have a changing to its label in the US at that time. And we'll talk a little bit about more that maybe escitalopram has a lower propensity for some of these side effects, but still possible. The other thing we found, there was a large study about 10 years ago in the UK, a population-based study, and there are some things we thought about as being much better with our newer antidepressants like SSRIs versus some of the older ones like tricyclics. And what they found is, well, maybe these SSRIs have more risk for falls than some of the tricyclics, and actually more risk for hyponatremia, particularly in older women who might be on a diuretic. And this doesn't mean yet that these are unsafe meds or we should be using tricyclics, but just keep in mind that we always have to keep the adverse effects in mind, particularly when we're looking at something that could potentially be limited therapeutic benefit. The other class of meds that's been meds that's been looked at is the actual medicines that have an FDA indication for the cognitive symptoms of Alzheimer's. So we have the cholinesterase inhibitors, of which kind of donepezil is the most well known. Did a number trial, had a nice name, CALM-AD, number of years ago, where they took people who had Alzheimer's, who were experiencing agitation, who were not on donepezil coming into the study, and they put them on donepezil or the placebo. And really what they found during that time is that over 12 weeks, donepezil was not any more effective than placebo in treating agitation as an endpoint. The other class of medication that we have, it's a class of one for is memantine, an NMDA receptor antagonist, which also has an FDA approval for moderate to severe Alzheimer's disease and is for the cognitive impairment. So again, another, not one, but two studies basically did the same thing, looking at memantine versus placebo. And in both studies, we really found that memantine was no more effective than placebo with agitation as your primary outcome. So what does this say kind of evidence-wise about antidepressants? Well, I think at this point we can say that SSRIs are first line for agitation. And we really want to try to avoid anticholinergic antidepressants, tricyclics and paroxetine for the potential cognitive and other concerns. But really, when you think about antidepressants for dementia, there's a higher bar really for prescribing them in depression. And that oftentimes, unless symptoms are quite severe, watchful waiting and a psychosocial program are kind of the first line treatments. So I put this together, sort of a kind of a summary of the different agents available in terms of SSRIs and what the evidence is. So really, citalopram probably has the largest evidence base. The CITAD trial and another a couple of other trials which showed some benefit. At a low starting dose, we're talking like 5 to 10 milligrams. But what do we have to watch out for? Well, there's this potential for QT prolongation. As I mentioned, we really don't have a dosing range established. You know, the study was at 30 milligrams. The FDA recommends 20. So that's a limitation. Well, what about S-citalopram? So S-citalopram is the racemic isomer of citalopram. So there's no, it's only the R enantiomer is removed, and it's the S enantiomer only. So theoretically, this should be as effective as citalopram, but with less propensity for adverse effects, because we know that the R enantiomer is where a lot of the QT prolongation comes from. Here we have a more limited evidence base, so theoretically it should be the same. There is an ongoing S-CITAD study. There is a potential QT prolongation, but less than citalopram. And really, I think we see this a lot if a CYP2C19 inhibitors can increase S-citalopram levels. So really, we just watch the dose. And usually we're talking about starting doses very low, 2.5 to 5 milligrams. Now, the other agent to think about is sertraline. So I wouldn't say, you know, I guess theoretically there's some, but there's very little concern for QT prolongation with sertraline. The levels aren't increased by the 2C19 inhibitors. However, on the flip side, we really don't have as much of an evidence base. So we don't know, there's been a couple of studies, one was positive, one was negative. So we don't know if that is this SSRIs for agitation limited to citalopram and S-citalopram, or is it more a class effect? I suspect it's more of a class effect, but we just haven't done enough trials to really back that up. Things to watch out for would be things like paroxetine. It's highly anticholinergic. It has more drug-drug interactions. Got a bad withdrawal syndrome if someone misses a dose. You feel dizzy, lightheaded, you feel electric shocks. Fluoxetine, very excellent antidepressant. Something I'm generally careful with because it has a long half-life. And it's got some drug-drug interactions. And really the other SSRI is fluvoxamine, we tend to avoid given in pretty much everything except for OCD, and I guess there's some thought it may be helpful in COVID, but it's really avoided given its amount of drug-drug interactions. So we talked about the antidepressants. I want to swing back a little bit to the antipsychotics. So these meds, they still do have a role despite this black box warning. Remember, the studies do show that there is some moderate efficacy, but our risk-benefit ratio has changed. Quality of life, as I said, remains the goal of care, but really you have to think, are these symptoms distressing, placing the patient or others at risk of harm? Provide informed consent and use shared decision-making. I always will review the black box warning with the decision maker for a patient with dementia that we're considering using these medications. And I have to say, in my experience, I mean, I don't know, thousands of maybe patients I don't see. I can count on less than two hands the number of people that I don't want my family member on that medication because of the black box warning. The reason being, if we're using these medicines very judiciously and we're kind of using them after other things have failed, keeping in mind that quality of life is our goal, that people are, families are willing to really kind of, it's an understandable risk. Very important, we always monitor closely for adverse effects, educating the caregiver on potential side effects. I try to check a baseline electrocardiogram from putting someone on an antipsychotic for dementia. The idea being that we're using something without an FDA indication, in which the evidence isn't great. We know there's potential for side effects. We really should be cautious. Watching orthostatic vital signs because of that, particularly for that alpha blocking, and really assessing gait and for extrapyramidal symptoms, which may be more prone to develop than folks who are being treated, younger folks who are being treated for schizophrenia with these meds. The other thing we want to do is really look for opportunities for dose reduction or discontinuation, keeping in mind that there's a risk of relapse. The American Psychiatric Association published a practice guideline on antipsychotics for agitation and psychosis back in 2015. It really had I think, some good practical advice here. Taper to discontinuation if you don't see clinically significant response after a 4-week trial. Even if someone responds, we want to attempt to taper or discontinue within about 4 months, unless symptoms have occurred with prior attempts at tapering. Remembering that, when you're working with someone who with dementia, sort of their body and brain are a moving target, and a dose of medication that someone may have tolerated a year ago may not be tolerable now. Really assessing at least monthly during taper and at least every 4 months after discontinuation, are we seeing signs of recurrence? Is the risk-benefit ratio favorable to try again? And the other one is really avoiding the long-actable injectable antipsychotic medications in this patient population, unless they have a clearly documented co-occurring chronic psychotic disorder. I mean, these are the kind of medicine, it's something that's, you can't get it back for 2 weeks or a month or 3 months. Really want to be cautious in using a medicine like that in an indication that's not as, as well documented or FDA approved. As always, be very cautious in patients with Lewy body, Parkinson's, and the Parkinson's plus syndromes, or anyone really with Parkinsonism, regardless of the cause. To kind of drill down a little bit into the specifics, what do we know about different meds? So risperidone, if you look at the clinical trials, that really has the most evidence for efficacy in the clinical trials among atypicals. Now, that's not real world practice, it's a clinical trial, but we do know there is a higher potential for EPS with risperidone among the atypicals. Orthostatic hypotension can limit its tolerability, and more in sort of the inpatient settings. There is no short-acting intramuscular formulation, and when we think about doses of risperidone for schizophrenia, we're looking at like up to 4 to 6 milligrams. I'm talking really starting like 1/4 to 1/2 milligram. Now, quetiapine or Seroquel is another medicine that's commonly used. The good thing about it is it seems to have some tolerability at low doses, and it's something that you can use as a PRN medication. You know, that histaminergic sedation can actually help with therapeutic benefit for insomnia, and as a PRN, it sort of seems to be somewhat anxiolytic and kind of can relieve symptoms in a short order, which makes it a little more effective, and kind of you can space out your dosing throughout the day when you know someone may sundown. The interesting thing is, though, evidence-wise, really the clinical trial evidence isn't good. Now, remember, no one's done studies on this since 2005, once the black box warning came out. It does contain the package insert contains a particular QT prolongation warning that you don't see on the other ones. And it's not, if you kind of look at the data, it doesn't appear to be any more likely to cause QT prolongation, unless AstraZeneca knows something that maybe the rest of us don't, and that's why it's on there. Orthostatic hypotension is also a possibility, and sedation can kind of limit tolerability. And there's no short-acting intramuscular formulation. So here we're thinking about, when you think about someone with schizophrenia maybe being on 400 or more milligrams of quetiapine, we're looking at starting doses of 12.5 to 25 milligrams. Other medicine we think often a lot about is olanzapine. There's more evidence for its efficacy versus quetiapine, though not as much with risperidone. May have a little less potential for QT prolongation, but not none. It also has that kind of ability to be used as a PRN, and there is a short-acting IM formulation. We think about sedation helping with insomnia. Downsides, the evidence really isn't as good as risperidone. It's mildly anticholinergic, so you got to keep your eye out for potential worsening of cognition, urinary retention. Like the other meds, orthostatic hypertension, sedation can limit its tolerability, and there is a potential for weight gain, though this doesn't seem to be as big of a problem as it is in younger folks. People with dementia are actually losing weight. How about aripiprazole? Now here we see, this was a second generation antipsychotic that was kind of the last to be introduced among this group. And so they really didn't get a chance to do many trials before the black box warning came. So in the limited amount of trials, it seems to be about as effective as risperidone. It has the least potential of this company, of these meds, for QT prolongation. But it's one really big caveat. It's got a really, really long half-life. So the dose that you start someone on, you may not seeing that steady state for a month. And I've had situations where folks, you start them on a dose, and then you see them a month later and they're incredibly Parkinsonian. And a lot of this is because we don't know, they haven't reached half-life. So I'm very cautious with aripiprazole for that reason. One med, sort of we think of as the index antipsychotic for a number of things, is haloperidol. So there's evidence for its efficacy. It only blocks dopamine, and it can be used as a PRN, and there's short-acting IM formulations, there's liquid, there's everything available. Well, what are the downsides? Well, you're certainly more propensity for EPS. When you look at the data, kind of differential mortality between agents, the only agent that really seems to separate is haloperidol from all the other agents. It's maybe appears to have, if you're using kind of risperidone as the index medicine of having a risk of 1 of death, haloperidol probably has a relative risk more of like 2. And for this reason, as the APA guidelines note, it's not recommended as a first-line agent. There are lots and lots of other meds that have been used for neuropsychiatric symptoms. I just want to touch on a few of them. Anticonvulsants, you'll see a lot of use of valproate. Kind of looking at the data is terrible for valproate. The largest study that was done, people who got valproate with Alzheimer's as a primary endpoint of agitation, did not affect the agitation. They had worsening cognition and smaller brain volumes after a year. So there's not good evidence. It doesn't mean we don't use it. And I found sort of in very low doses in certain situations with people who have sort of manic-like symptoms, it may help. But remember there that the evidence really isn't on your side. There's carbamazepine, where there's actually a fair amount of evidence for carbamazepine. Again, it's a very hard medicine to use, interacts with a lot of meds. You have to draw blood for levels. There's this concern for agranulocytosis, so it doesn't get used very often. Benzodiazepines, I mean, kind of it's hard to never say never, but it's something that I'll say avoid their use as much as possible, except for emergencies. There's the increased risk of falls and delirium. If you're going to use a medicine, I generally would start with lorazepam at a low dose, the lowest dose of 1/4 milligram. And why lorazepam? Well, it doesn't have active metabolites, number one, and it doesn't have a long half-life, which kind of makes it most favorable. I talked about cholinesterase inhibitors and memantine, though they're FDA approved for cognition and Alzheimer's. They're really not effective as a primary treatment for agitation, though I can say they may, particularly memantine, delay agitation in someone who was going to develop it anyway, but not first-line treatments. Always remember your kind of geriatric principles: start low and go slow. So kind of wrap up with our case vignette. So you have your 72-year-old patient with moderate Alzheimer's has become more agitated. They're pacing, they're checking doors and yelling for no particular reason. He talks to himself as hallucinating, but really isn't distressed. These symptoms start around 2 and persist for several hours. Happens both at home and his day program. So you do a thorough evaluation. What do you do? And here I put this up to kind of say, well, we know that haloperidol is not a first-line agent, and the evidence is not very good for divalproex, Depakote. So the question becomes, do we try sertraline, quetiapine, or no medication? So no medication, or let's say we've talked to the family, there's urgency to manage here, it's happening in multiple environments. I think the medication is really reasonable. I think your decision point here is, do you use an SSRI? Do you use quetiapine? And that's somewhat a judgment call. We know that SSRIs probably aren't as effective for the severe symptoms. They're more for mild to moderate, and definitely would be a first line for that. If we're talking about a symptom that's pretty severe, then maybe we can consider some of that, assessing some of that risk benefit and moving to an antipsychotic. But you could kind of go both ways. Take home messages, the meds, let's just try to avoid their use altogether through further evaluation on pharmacologic techniques as best we can, though that's not possible. SSRIs are sort of first line for agitation. And then there's a higher bar for antidepressants to treat depression and dementia. And if you're going to use an antipsychotic, informed consent, shared decision-making, watch closely, and haloperidol is not your first line agent. So that is all I had on my slide.